Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the PALM series, which is practical aspect of lab medicine. As you are aware, all our lectures are available on YouTube. We also have a Telegram group which you can join to access all lecture related information. We have a Google Drive where the PDF of all lectures are uploaded. And this is the disclaimer. Here we would like to emphasize that we do not sponsor any company, group or organization. Reference to any particular brand is purely at the discretion of the presenter, solely done for understanding and explaining the subject. We do not subscribe to any particular brand. We are with phase 3, which is recorded pathology lectures. And today we have PALM-05, which is biomedical waste management. And we are streaming from the famous Peerless Hospital, Kolkata. And to talk on this, we have Dr. NARAYAN Chaudhuri, who is the Chief Microbiologist and Senior Consultant, Department of Microbiology and Molecular Biology, and Infection Control Officer of Peerless Hospital and Research Center, Kolkata. He has published around 88 papers and articles in national and international journals. He is an NABL lead assessor and technical assessor in microbiology, serology, molecular testing, flow cytometry for medical laboratories. He is NABL-nominated Trainer of ISO 15189-2022 training program of NABL. He is an advisor microbiology and molecular biology for Medinova Diagnostics, Kolkata. He had stood first in the medical stream in West Bengal Joint Entrance in 1987. He's done his MD in microbiology from University College of Medicine, Kolkata. And he's an honorary faculty member of St. Xavier's College, Kolkata Department of Microbiology, ethics committee member of Fortis Hospital, Anandapur, life member of IAMM, IHISI, ISCCM, AHA, and CAP, executive member. With this, I would request Dr. NARAYAN Chaudhuri to start his talk on biomedical waste management in medical laboratories. Over to you, Dr. NARAYAN Chaudhuri. Thank you so much.
Hello everyone. This is Dr. NARAYAN Chaudhuri, Chief Microbiologist of Peerless Hospital, Kolkata. I will speak on biomedical waste management in medical laboratories in the COVID plus era. So definition of biomedical waste is any waste generated during diagnosis, treatment or immunization of human beings, animals or research activities pertaining thereto or in the production or testing of biologicals or in health camps, including categories mentioned in Schedule 1 and other infected wastes. We must note that as per the biomedical waste outsource agencies, they do not consider urine, stool and vomitus as biomedical waste even if infected. They are considered as municipal waste and should be discharged into the sewerage as that happens in our homes. But in the hospitals, there is a bit of controversy regarding the urine and stool samples which are used in the microbiological labs for testing, which may be infected. So in many of the labs, we are treating is as biomedical waste and discarding into yellow or red containers or as liquid waste, whichever is applicable, which will be discussed in course of my presentation. So according to WHO, nearly 85% of all waste generated by hospitals is general waste, about 10% is biomedical waste, and only 5% is other waste such as radioactive and chemical wastes. In a large tertiary care hospital of India, biomedical waste generated is about 1.5 kg per bed per day as against 2.8 kg per bed per day for a similar sized hospital in USA. So we are generating around half of the biomedical waste in our hospitals, Indian hospitals, compared to the USA scenario. So who are at risk due to improper, unhygienic and unscientific disposal of biomedical waste like this? Not only the doctors, paramedical staff, the nurses, the ward boys, sweepers, also the municipal workers, the patients, their attendants and public at large, including the animals, the environment and the plants. So health impacts of biomedical waste include, what are the health impacts of biomedical waste? Exposure to infectious biomedical waste can result in disease or injury. It may contain infectious agents, toxics or hazardous chemicals, pharmaceuticals, radioactive waste and waste herbs. Pathogens in infectious waste may enter the human body through puncture, cut in skin, mucous membranes, or by inhalation or ingestion. Sharps may not only cause cuts or punctures but also infect the wounds if they are contaminated with pathogens. Poor hospital waste management may cause the following. They may cause COVID-19, which we have already seen during the COVID era. They may cause hepatitis B, C, and HIV infection, particularly through Sharp's injury. Gastroenteritis may be acquired through ingestion. Respiratory infection through inhalation. Bloodstream infection, cutaneous and subcutaneous infection, these may also occur through Sharp's injury. Radioactive toxicity may occur in not only in the radiological laboratories but also in the lab where we are using radioisotopes or radioimmunoassay, which is usually not used much nowadays. Health problems associated with air and water pollution. This may also occur from improper disposal of biomedical waste. So what is the need of biomedical waste management in hospitals? So our health department, National Health Department, identified this need, and the first legislation that came into vogue, the environmental legislation in India concerning biomedical waste, that is the Biomedical Wastes Management and Handling Rules of 1998. But these rules was not applicable across the country. Each and every state had its own pollution control board, and each and every state formulated its own guidelines. For example, till a few years back, till before 2016 in West Bengal, the recyclable waste, that is the plastic waste, was collected in blue marked boxes or blue containers or blue plastic bags. In some other states, it was done in red plastic bags. So to bring about an uniformity in the system across the country, the biomedical waste management rules was modified in 2016, and now this single rules is applicable across the country in all the states. All the pollution control boards, the state pollution control boards, have to abide by the national biomedical waste management rules. But there were certain amendments that were required in this rule. For example, in the 2016 guidelines, it was mentioned that 10% sodium hypochlorite should be used. But it was revised. It was a mistake. It was revised in 2018 to 1 to 2% sodium hypochlorite. And certain other amendments also came into vogue, including pre-treatment of the laboratory waste at site and blood bags at site, on site, before handing over those to the biomedical outsourced agencies. Okay, so these rules were modified in 2018, and after that another amendment came in 2019. Then the National Biomedical Waste Management Guidelines, that is the COVID guidelines, when COVID came into vogue, these guidelines came into being on 19th April 2020, which was subsequently modified in 2021 and 2022. And the CPCB Immunization Biomedical Waste Management Guidelines came into vogue in 2021. So every year we are having some amendment, and we have to keep ourselves updated with the latest guidelines that are being coming into vogue. So all the labs and the healthcare workers have this responsibility of keeping a tab on the latest National Biomedical Waste Management Guidelines. So what are the salient features of the new rules that came into vogue in 2018 pertaining to the laboratories? So the first and foremost rule is pre-treatment of laboratory waste, microbiological waste, blood samples and blood bags that is generated in the blood banks by disinfection or sterilization on site as per WHO guidelines of safe management of wastes from healthcare activities, and as per WHO Blue Book 2014, before sending those for incineration or other treatment as applicable. Provide training to all the healthcare workers. Immunize all the healthcare workers against hepatitis B and tetanus. That is important. These two, immunization of all healthcare workers is important because all healthcare workers handle biomedical waste. And as per the COVID guidelines, we have to immunize the healthcare workers against COVID also. Establish a barcode system for bags or containers containing biomedical waste for disposal. Report the major accidents. Biomedical waste has been classified into 4 categories instead of 10 to improve the segregation of waste at source and to minimize the confusion amongst the healthcare workers regarding the categories. The new rules prescribe more stringent standards for incinerator to reduce the emission of pollutants into the environment. There are still some hospitals, some big hospitals or medical colleges which have incinerator on site, but the latest National Biomedical Waste Management Guidelines have put into certain stringent measures to minimize the risk of air pollution from incinerators. So state government has to provide land for setting up common biomedical waste treatment and disposal facility coming from the different diagnostic centers and the hospitals. No occupier shall establish on-site treatment and disposal facility if a service of a common biomedical waste treatment facility is available within a distance of 75 kilometers. So within a radius of 75 kilometers, there cannot be 2 different centers using incinerators. So that has been done to reduce air pollution. Operator of a common biomedical waste treatment and disposal facility should ensure the timely collection of biomedical waste from the healthcare facilities and assist the healthcare facilities to conduct training. The biomedical waste management guidelines are not applicable to radioactive wastes covered under the MSW rules 2016, lead acid batteries, hazardous wastes and e-wastes generated in the laboratories or diagnostic facilities or hospitals. So there are separate national guidelines for this type of waste. And this type of waste consists only about 5%, 4 to 5% of the waste generated in hospitals. Dead fetus below the viability period as per MTP Act 1971 can be considered as human anatomical waste. Such waste should be handed over to the operator of common biomedical waste treatment facility in yellow bag with a copy of official MTP certificate from the concerned obstetrician or the medical superintendent of the hospital. So these are certain salient features of the new rules. Now the National Biomedical Waste Guidelines concerning COVID treatment facilities and COVID diagnostic facilities came into vogue in April 2020. So they added, you have to certain other categories like keeping separate color coded bins, bags, containers and maintain proper segregation of waste as per the biomedical waste guidelines of 2016 and 2018 and CPCB guidelines for implementation of biomedical waste. So the same guidelines are applicable to COVID treatment and COVID diagnostic facilities as well, but as a precaution, double layered bags, that is using 2 bags in place of 1 bag, should be used for collection of the COVID waste so as to ensure adequate strength and no leaks. Use dedicated collection bins labeled as COVID-19 bins to store COVID-19 waste and keep separately in temporary storage room prior to handing over to the authorized staff of the common biomedical waste treatment and disposal facility. Maintain separate records for fast tracking and disinfect the inner and outer surface of containers, bins or trolleys with 1% sodium hypochlorite solution daily. Collect the used PPEs like goggles, face shield, splash proof apron, plastic coverall, hazmat suit, gloves, nitrile gloves, that is all things that are made of plastic and that are COVID-19 waste, contaminated waste, into red bags. Collect used masks, that is the biodegradable waste. Used masks including non-plastic waste, including triple layer mask, N95 mask, head cover, cap, shoe cover, disposable linen gown, non-plastic or semi-plastic coverall in yellow bags. Pre-treat or autoclave all the samples, that is the COVID-19 samples in VTM containing nasopharyngeal swabs, oropharyngeal swabs after testing. So when they are disposed of, plastic vials, vacuotenus, Eppendorf tubes, plastic cryovials, pipette tips that are used in the diagnostic facilities for PCR testing as per Biomedical Waste Rules 2016 and 2018 and collect in red bags. So these should be autoclaved first and then put into red bags. We are using certain autoclavable bags which do not melt after autoclaving for 60 minutes. So these autoclavable bags are costly, but the biomedical waste disposal facility, they also provide the hospitals with autoclavable red bags in which, or yellow bags in which the waste can be autoclaved and then put into another yellow or red bag before handing over to the outsourced agency. So what's the message for non-COVID testing lab areas? The 2020 guidelines are mainly for COVID facilities and COVID testing labs. What about other laboratory areas like hematology, clinical pathology, serology, biochemistry and microbiology who are receiving samples from or for other parameters from patients suffering from COVID or other infectious agents? So there are several reports of lab personnel contracting COVID and other infectious diseases like influenza, tuberculosis, hepatitis and HIV, hepatitis B, hepatitis C and HIV while working in the laboratory or hospital. So following the existing biomedical waste management rules of 2016 to 2022 and COVID protocols meticulously can save all lab personnel and hospital personnel from nosocomial or lab acquired COVID and nosocomial or lab acquired infectious diseases, other infectious diseases like HIV or hepatitis or TB. So work area and equipment disinfection while working with infectious samples. Irrespective of the containment level, work surfaces and equipment must be decontaminated after specimens have been processed. Pay attention to all surfaces that may have come into contact with specimens or specimen containers. Use a disinfectant solution with proven activity against enveloped RNA viruses, HIV, hepatitis C, and COVID. These are enveloped RNA viruses, and hepatitis B is a DNA virus. So these are all these can be disinfected using certain chemicals like 0.5 to 1% sodium hypochlorite or bleach, 1000 ppm or 0.1% for general surface disinfection, and 10,000 ppm or 1% for disinfection of blood spills. Around 70% ethyl alcohol or isopropyl alcohol is an alternative chemical and safer chemical than sodium hypochlorite or bleach for surface disinfection. Or we can also use 0.5% hydrogen peroxide or quaternary ammonium compounds or phenolic compounds for surface disinfection. Particular attention should be paid to the contact time, which should not be less than 20 minutes. So usually we are disinfecting spills, blood spills with 1% sodium hypochlorite for 20 minutes, and the other surfaces like the surfaces of laminar airflow cabinet or biosafety cabinet are usually, they can be disinfected using 0.1% sodium hypochlorite. So this is to minimize the use of sodium hypochlorite because sodium hypochlorite is a toxic chemical. So waste, coming into waste classification, as we have already told, general waste or non-infective waste comprises around 85% of the waste generated in hospitals or diagnostic facilities, and biomedical waste or infective waste is only around 10%. So these non-infective waste are generally discarded into black marked containers, black marks plastics. But now all the municipal corporations across India, they have again divided this general waste or the waste generated from our homes, the home generated waste, into biodegradable and non-biodegradable waste. So non-biodegradable waste is usually the wet waste, that is the vegetables, the food materials that we are discarding. So that is biodegradable. Even paper is biodegradable. And non-biodegradable waste is the biodegradable waste is the wet waste, that is the paper and the vegetable waste, the food waste that we are discarding, that is the biodegradable waste. It should go into green plastics or green containers that are provided by the municipal corporations. And the non-biodegradable waste are usually the plastic and glass items which are non-biodegradable. So they should be discarded separately into blue marked containers or blue marked plastics. So this general municipal waste is again divided into biodegradable and non-biodegradable waste. So they are disposing of this because the non-biodegradable waste is recycled and the biodegradable waste is used for landfills. Okay. But in the hospitals and the laboratories, we are provided with the black marked containers for collecting the non-infective waste. Be sure to discard the general waste or non-infective waste into the black containers. Do not discard them into the yellow or red bins, because that will increase the burden of the biomedical waste for the outsourced agencies. So whenever we are disposing of the plastics, that plastics of the syringes, the covers of the syringes or needles, we should dispose them into black containers, not into red containers, because they are non-infected. So this should be borne in mind. Now, classification of infectious waste. Infectious waste may be classified into infectious shrubs and infectious non-shrubs. Infectious non-shrubs include the tissues or histopathological waste, the microbiology waste, the waste generated in blood banks, the waste generated in biomedical, biotechnological waste, infectious plastics, infectious non-plastics, and the liquid waste. So the protocols include the most important and at the point of generation is the segregation. The waste should be segregated into different color coded bins at the point of generation itself by the healthcare worker concerned. Doctors often, they are very busy. They are not disposing of the biomedical waste at the point of generation. They are keeping it for the nurses or the housekeepers to dispose of. This is a very bad practice for the doctors. Whenever they are using the shrubs, they should dispose of the shrubs themselves. They should dispose of the gloves themselves and dispose them off into different color coded bins. This should be borne in mind by the doctors, the busy practitioners also, because it doesn't take much time. It is only the mindset that has to be developed accordingly. Then the packaging, transportation and storage of waste. Within 48 hours, it should be transported into designated closed trolleys and stored on site in a separate area that is away from the testing areas or the hospital area or the lab area. There should be a storage space, and this storage space also should be segregated into 3 different or 4 different categories, where we are storing the red bins, red plastics in one area, the yellow in a separate area, the white in a separate area, and blue mark boxes in a separate area. And they should be weighed before handing over to the outsourced agency. So outsourced agency visits the hospitals or the diagnostic facilities at certain intervals. In case of hospitals who are generating a lot of biomedical waste, they are visiting them regularly in the morning, sometimes twice a day, and collecting the waste. And the diagnostic facilities were generating less biomedical waste. Usually it should be disposed of every 48 hours, that is every alternate day they are collecting the waste from these facilities. So no waste should be stored beyond 48 hours. That is a very important message. And the final disposal is done by the outsourced agency, and it should ensure complete destruction of the microorganisms, the pathogenic microorganisms. So this is a poster given by Medicare, whom we are outsourcing. There are other agencies like GreenGen and lots of other agencies all over India who are collecting this biomedical waste. They are known as the common biomedical waste disposal and treatment facilities. They have these facilities. So in West Bengal, we have several common, I think 5 or 6 common treatment facilities. The nearest to us is in Hooghly. So biomedical waste management, this poster is based on the biomedical waste management rules of 2016 and 2018. And these national biomedical waste guidelines are followed across India. This is a symbol for cytotoxic waste, and this is a symbol for biohazard. This is the biohazard symbol. This biohazard symbol should be used for all types of containers containing biomedical waste. And this cytotoxic symbol should be used for containers like yellow bins where cytotoxic materials like discarded or expired medicines are discarded. So whatever goes into yellow, we are discarding the biodegradable waste. And there are only 2 exceptions, that is the blood bags generated in the blood banks and microbiological and biotechnology waste, which are generated in the microbiology labs. They are generated in plastic petri dishes, but these should be disposed of into yellow, not into red, after autoclaving. So blood bags after autoclaving should go into yellow, and microbiological waste or biotechnology waste after autoclaving should go into yellow marked boxes or yellow marked bins. And others are all biodegradable waste like body parts, placenta, human tissue, specimens, surgical waste, cotton waste, bandages, linen, bedding, dressings, solid plaster, casts. And expired medicine and cytotoxic waste should be discarded into yellow marked bins with cytotoxic symbol as well, in addition to the biohazard symbol. Whatever is made of plastic is recyclable. So IV tubes, saline bottles, syringes without needles, vacuum-tenors and blood containers or blood vials, which are used in biochemistry, hematology and serology laboratories, they should also be pre-treated by autoclaving before being disposed of into red bags or red containers. Urine bags, catheters or urine samples also, urine samples and stool samples generated in the laboratory, we are usually discarding into red bins because they are contained in plastic containers. Catheters, stents, gloves, aprons and other tubings made of plastic should go into red containers. Now whatever is sharps, that is blades, these are metal blades or metal scalpels, lancets which are also made of metals, needle tips after burning which are also made of metals. These sharps should go into puncture proof white marked boxes, usually translucent boxes. And whatever is made of glass and big metals like metallic implants which are discarded. And anything made of glass, whether it is broken glass or whether it is intact glass, but glass containing biomedical waste like vials, ampules, broken slides or intact slides generated in the hematology laboratories or clinical pathology laboratories or microbiology laboratories. Metallic implant, these should go into blue marked boxes. And another thing is that the cytotoxic residue and the residue which are cytotoxic, which contained expired medicines in glass vials, they should also be going into blue mark boxes, which should additionally contain a cytotoxic symbol in addition to the biohazard symbol. So this is again a slide which discusses these categories of the waste, 4 categories of the biomedical waste. So yellow, type of waste: human anatomical waste, animal anatomical waste, soiled waste, expired or discarded medicines, chemical waste, discarded linen, mattresses, beddings contaminated with blood or body fluid, routine mask and gown. These should be disposed of into yellow colored non-chlorinated plastic bags or containers, and they are usually subjected to incineration or plasma pyrolysis or deep burial by the outsourced agency. The discarded medicine shall be either sent back to the manufacturer or disposed by incineration. Microbiology, biotechnology, and other clinical lab waste as well as the blood bags should be pre-treated by autoclaving in safe plastic bags, autoclavable bags or containers, before being put into yellow containers or yellow bags, and then sealed and stored and disposed of by the biomedical waste agency by incineration or plasma pyrolysis. Chemical liquid waste, separate collection system leading to effluent treatment plant is needed for this. So after resource recovery, the chemical liquid waste shall be pre-treated before mixing with other wastewater before being disposed of into the general sewerage. Now red, contaminated waste that is recyclable, that is the plastic waste, should go into red colored non-chlorinated plastic bags or containers. See, all the things are non-chlorinated. Even there is no need of putting sodium hypochlorite in puncture-proof containers, which are white marked boxes and blue marked boxes. It was in vogue earlier, but after 2018, the National Biomedical Waste Management Guidelines, they have reduced the use of sodium hypochlorite, which is a toxic chemical. So these should not be put into any of the plastic containers. Either it is yellow, red, white, or blue marked boxes. No need of putting sodium hypochlorite in any of the containers. That is an important message. So whatever goes into red colored non-chlorinated plastic bags or containers, they are ultimately disposed of by autoclaving or microwaving or hydroclaving, followed by shredding or mutilation or combination of sterilization and shredding. Treated waste is sent to the recyclers. Plastic waste should not be sold to landfill sites. They should be recycled. So waste sharps, including the metals like blades, scalpels, etc., they go into puncture-proof, needles, etc., go into puncture-proof, leak-proof, tamper-proof containers, should not contain sodium hypochlorite, and ultimately they are treated by autoclaving or dry heat sterilization, followed by shredding or mutilation or encapsulation in metal container or cement concert. Glassware and metallic body implants go into puncture-proof, leak-proof boxes or containers with blue colored marking. No need of putting sodium hypochlorite. They should not contain sodium hypochlorite. They should be dry. And ultimately they are disinfected or they are treated through autoclaving or microwaving or hydroclaving and then sent for recycling. So do's and don'ts for sharps management. Sharps have the highest potential to spread infection. Sharps have the potential to induce the microorganism directly into the bloodstream. 80% of the infection spreading is due to cross-contamination, that is using an infected needle or by accidental needle stick injury or needle prick injury, usually after recapping a needle in an improper manner or by some other means. So handle sharps very carefully. While disposing of syringes, cut or burn the needle by inserting into electrical needle destroyer. Needle burners are not permitted by certain pollution control boards because they usually cause air pollution. So needle burners are not usually recommended, but needle cutters should be used to cut the needles by inserting into electrical needle destroyer. Sever the physical metal cutters, that is the physical needle cutters. They may not be electrical also. There are certain physical needle cutters. They should be used in the laboratories and hospitals for cutting the syringes. Sever the neck of the syringes in the cutter portion of the destroyer. Do not leave syringes intact, as those can be recapped and reused by some unscrupulous agencies. And they may contain some infectious pathogens like hepatitis B, which may remain intact, which may remain viable for a long duration of time. Throw the cut portion, use scalpels, blades, needles, cut portion, needles, etc. into white puncture-proof containers. Throw the plastic body of the syringe in red bags. Dispose of the containers when either 3/4 full or every 48 hours, whichever is earlier. So you cannot keep the white containers or the blue mark boxes for more than 48 hours in your facility. They have to be discarded after that. That is handed over to the outsourced agency. Do not put uncut naked syringes in red bags. This will result in prick injuries of the housekeepers, mainly housekeeping staff. Puncture of the bags may be caused by this, and spillage of the waste may also be caused by this. So be very careful. In case of any needle stick injury, inform the higher authorities immediately for necessary monitoring and treatment. So, these are the standards for liquid waste. Liquid chemicals should be neutralized with manufacturer recommended neutralizing agents before being disposed of into sinks. Larger facilities or hospitals should have an ETP on site. Usually a hospital which has more than 200 beds should have an ETP on site, effluent treatment plant on site, and smaller facilities should have an STP, that is sewage treatment plant on site. The effluent generated or treated from premises of occupier or operator of biomedical waste treatment and disposal facility before discharge into the sewer should conform to the limits mentioned in the 2016 national guidelines. I am not going into the details of these guidelines. All the guidelines are available on the website of the Ministry of Health and Family Welfare. Sludge from the ETP shall be given to common biomedical waste treatment facility for incineration or to hazardous waste treatment storage and disposal facility for final disposal. So pre-treatment of hazardous waste. In many areas, chemical treatment is used, particularly in the HIV laboratories, by using 1 to 2% sodium hypochlorite, having 30% residual chlorine for 20 minutes. This can be done by bleaching solution as well. So, or any other equivalent chemical that should demonstrate log 4 10 to the power 4 reduction, that is 4-lot reduction efficiency for microorganisms. So that is one option. But usually all the hospitals and laboratories are pre-treating the microbiological, laboratory and highly infectious biotechnology waste and the blood banks in the blood bags in the blood banks. They are usually pre-treated by autoclaving. There are certain guidelines regarding this autoclaving. The autoclave should be dedicated for the purposes of disinfecting and treating biomedical waste. So the labs who are having microbiology laboratory, they should have 2 different autoclaves. One for the clean autoclave for sterilizing the media, and the holding time of that is usually 15 to 20 minutes. And another autoclave, that is the discard autoclave, that should be used for pre-treating the biomedical waste, usually the microbiology, biotechnological waste and the blood bags. So that autoclave, we are usually using the gravity flow autoclaves, and the holding time for that is 60 minutes. So gravity flow autoclaves mostly used in the laboratories. Medical waste should be subjected to a temperature of not less than 121 degrees Celsius and pressure of 15 pounds per square inch for an autoclave residence time of not less than 60 minutes. So there are 2 different times. The autoclave heating time, that is the heating time is the time to reach 121 degrees Celsius, so that point of water is 121 degrees Celsius when a pressure of 15 pounds is reached in the autoclave. So that is the heating time. It usually takes around 15 to 30 minutes. And after reaching that temperature 121 degrees Celsius, which is ensured at a pressure of 15 psi, the holding time at that temperature of 121 degrees Celsius should be at least 1 hour. So that is the holding time. So total autoclaving time is around 1 hour 15 minutes to 1 hour 30 minutes. This is very important. And in the facilities, we're using vacuum autoclaves or the horizontal autoclaves, usually used in the CSSDs, central sterile supply departments of the hospitals. The medical waste shall be subjected to a minimum of 3 pre-vacuum pulses to purge the autoclave of all air. The air removed during the pre-vacuum cycle should be decontaminated by means of HEPA and activated carbon filtration, steam treatment, or any other method to prevent release of the pathogens. The waste shall be subjected to a temperature of not less than 121 degrees Celsius and a pressure of 15 psi per an autoclave residence time of not less than 45 minutes. So for vacuum autoclaves, the holding time is 45 minutes, but for gravity flow autoclaves, which we are using in most of our facilities, the holding time should be 60 minutes. And the autoclave efficacy, whether the autoclave is acting effectively or not, should be checked with chemical indicators with every load. There is a color change which is defined by the manufacturer. That color change should occur after the autoclave cycle to ensure that the autoclave cycle has been effective. And this chemical indicator should be used with every load, and the records of that should be maintained by the laboratory. And biological indicators, the national guidelines tell that the biological indicator should be used at least weekly. Ideally, every cycle should be monitored by a biological indicator, which is usually done in the CSSDs, but to reduce the cost, these biological indicators are costly. So at least once every week, that is the recommendation for use of the biological indicators for the clean and dirty autoclaves, that is the discard autoclaves. And these biological indicators are usually they have a double jacketed instrument. That the outer vial is a plastic vial which contains the spore strip, and this spore strip is of a very much heat resistant bacteria, that is Geobacillus stearothermophilus, but it is killed at a temperature of 121 degrees Celsius for 60 minutes. For usually 15 to 20 minutes it's killed. So Geobacillus stearothermophilus bacteria, being a thermophilic bacteria or a heat resistant bacteria, this biological indicator should be incubated at a higher temperature, not at 37 degrees Celsius, but at 55 to 56 degrees Celsius. So all laboratories should have a water bath or an incubator set at 55 or 56 degrees Celsius for incubating the biological indicators after they are used in the autoclaves, and these should be incubated for at least 24 hours. So these biological indicators contains the spore strip, that is Geobacillus stearothermophilus spores in a strip or a paper, which is in the outer plastic jacket, and inside it contains a glass vial which contains the media, and this media is usually purple or violet colored media. So after the autoclave is over, before the autoclave, this biological indicator, whenever it is put into the autoclave, should be put at the center of the autoclave where there is minimal penetration by the steam. So steam should reach that area and sterilize the spores contained in these biological indicators. So after the autoclave is over, the biological indicator should be pressed with so that the inner vial containing the media is broken. The glass vial is broken and the media comes into contact with the spores. Okay, so in presence of media, the spores will germinate. If the spores are viable still, they will germinate. And after germination, due to a biochemical reaction, the color of the media will change from violet or purple to yellow within 24 hours. So after incubation, we are finding, if we are finding that there is a color change, then the autoclave was not acting effectively. So autoclave didn't achieve the temperature of 121 degrees Celsius, which could have killed the spores. So spores have remained viable. So if there is a color change, it indicates that the autoclave has to be serviced or changed, or accordingly that calls for a intervention on part of the autoclave user. But if there is no color change after 24 hours of incubation, the autoclave cycle was effective. So this is very important to check the efficacy with chemical indicators with every load and biological indicators once every week. That is the national recommendations, and after that the biological indicator should be incubated at 55 to 56 degrees Celsius. And the lab should ensure that there is no cluttering in the autoclave room. The clean and dirty autoclave should not be placed side by side because there may be a chance of cross contamination. The steam is generated here, so this room should be fitted with exhaust. Usually, ideally, the lab should have two different rooms where the clean autoclave and dirty autoclaves are placed. And if they are placed in the same room, they should be segregated by a barrier, so there is no chance of cross contamination. And biomedical waste collection, labeling and transport. Pack and label the waste right at the point of generation. The waste should be labeled. Date of production, place of production and waste category should be written in the label. And it should be transported in closed trolleys, not in overloaded open trolleys. And excessive spillage of waste may occur if it is transported in open trolleys. And the person who is transporting the biomedical waste should don a proper PPE, personal protective clothing. So, and these are the standards for liquid waste. Liquid chemicals should be neutralized with manufacturer recommended neutralizing agents before being disposed of into sinks. Larger facilities or hospitals should have an ETP on site. Usually a hospital which has more than 200 beds should have an ETP on site, effluent treatment plant on site, and smaller facilities should have an STP, that is sewage treatment plant on site. The effluent generated or treated from premises of occupier or operator of biomedical waste treatment and disposal facility before discharge into the sewer should conform to the limits mentioned in the 2016 national guidelines. I am not going into the details of these guidelines. All the guidelines are available on the website of the Ministry of Health and Family Welfare. Sludge from the ETP shall be given to common biomedical waste treatment facility for incineration or to hazardous waste treatment storage and disposal facility for final disposal. Hello everyone. This is Dr. NARAYAN Chaudhuri, Chief Microbiologist of Peerless Hospital, Kolkata. I will speak on biomedical waste management in medical laboratories in the COVID plus era. So reduce, reuse and recycle, the 3 R's should be remembered by all of us, and we should remember to practice meticulous hand hygiene to reduce the chance of nosocomial or lab acquired infection. So that is all from me. Thank you all.